Thank you, Manuela, and good afternoon. Just want to make sure people at the back can hear me. How's the sound there? Good? Okay. So I am a pathologist working for the past 35 plus years as a diagnostic pathologist and have been through the evolution of prostate pathology from identifying high-grade PIN to making modifications in the Gleason system, making sure that us as pathologists can recognize prostate cancer correctly. Have seen some amazing development in pathology from staging to precision medicine, and the advent of AI has given us a very unique perspective to even further impact our role in the management of patients with urologic cancers. So with that, this is my opportunity, having worked with Ibex for now almost 5 years, to give you my perspective, not only as a diagnostician, but where an Ibex-type solution is really incredible, not only from the pathologist's perspective, but really serving the patients. So if one takes a look at the prostate biopsy scenario worldwide, arguably the numbers are around 8 to 10 million prostate biopsies being performed each year. And people have argued whether these numbers are going to go down because of PSA screening guidelines or MPMRI coming in with a reduced number of biopsies, or are we going to see an increased number of biopsies because of patients with active surveillance, patients with an aging population? And the current trend is that while the numbers are stable, it's very likely that we're going to see a slight increase in the number of prostate biopsies we're going to see in the next 5 years or so at least. And during these 30 years that I described in the evolution of prostatic disease management, the role of the needle biopsy has expanded considerably to not just providing the gold standard for the diagnosis, that is that the patient has prostate cancer, but in a needle biopsy, by defining some parameters, really defining how patients should be stratified, including patients who receive active surveillance, radiation therapy, surgery, et cetera. And so just to take the NCCN guidelines, which most designated cancer centers in the United States use as an example, you can see that the stratification, and each of these stratification categories have patients that then go into very distinct management decision algorithms. And so with patients with low-risk disease, what is very important, as you know, is the Gleason grade of the cancer, the number of cores involved, 3 or less, and the amount of cancer in each core. And we know it's not just 50%. If they're discontinuous foci, they have to be calculated differently. So the amount of cancer is really very important. And based on this, patients really make major decisions of whether they should be treated or not. In the favorable intermediate risk category, where there is a pressure to give some sort of treatment, again, the definition of the involvement of cores is different. It is less than 50% of the biopsy cores involved. So if they had 12 biopsies, then 6 had to be involved. So estimating whether there's cancer or not, what's the Gleason grade and score, and the number of cores involved, and the percentage is really, really key in these needle biopsies. So what is the opportunity statement for us as pathologists when we are dealing with prostate cancer, and how can we influence that management? So as pathologists, we want to diagnose prostate cancer accurately. And with pertaining to active surveillance, is not only recognizing cancer, it's recognizing all the cores with cancer and all the different foci, because different foci can lead to different estimates of continuous and discontinuous foci that lead to that 50% change. Of course, we provide the Gleason score, quantitate the amount of tumor, and provide all of this information in a report. So the challenge/opportunity in the field has been the underdiagnosis of cancer. And when one just looks at the literature, that means pathologists reviewing each other's work, there's about a 1.7% underdiagnosis of cancer. I'm going to show you how AI has changed these numbers. And an overdiagnosis of cancer in about 1.5%, ranging from the numbers I showed you. We know with Gleason, there's an entire issue with intra and inter-observer reproducibility. The measurement is an eyeball measurement, and there are, of course, technical challenges with presenting the report in a succinct fashion. So now, in addition to all of this, this is our challenges on a day-to-day basis, right? We have a high number of prostate cores and biopsies to look at in each core. And depending on if you're just in a GU service or primarily GU service or just doing many others, if you have just 10 or 15 cases and 8 or 10 cores, you're looking easily at over 100 plus cores per day. Now, we know that anatomic pathologists are rarely involved with misdiagnosis, but when it occurs, it is severe. And in the prostate, the latest numbers we had, and this is a couple of years ago, the incidence of being involved medico-legally is rare, but when it occurs, the numbers are relatively big. We also know that not infrequently, as you're looking through 20, 25 slides on a case, the last slide has a small focus, and you're already tired looking at all the different foci trying to screen for cancer. We also have to worry about ordering recuts, immunohistochemistry, clinicians calling, and you always almost wish you had somebody who screened the cases and told you what you had to do with these cases. The clinicians are expecting greater degree of subspecialization from us, and of course, as we all know, we have a shortage of colleagues in the community, and the newer generation wants a flexibility in time and geography to work. So all of these are challenges that we face, and I will show you in the next 10 minutes that all of these are significantly enhanced and addressed by the digital pathology AI solution, including the one that Ibex offers. So now just when you're looking, and AI is the trend in the next couple of years for us to understand, to really understand which is a good AI product, we need to understand sensitivity of the test, specificity of the test, things we know well as pathologists, positive predictive value, kappa values, et cetera. But a concept that is not well understood by most pathologists is area under the curve, which is very commonly used in machine learning because it's binary. Is there cancer or not? It's looking at just two aspects. And when you look at area under the curve, the model tries to predict whether an input belongs to one of those two classes. So if you do heads or tails, that's 50% chance. If the AUC is 1, that is perfect, right? So you want to be closer to 1 when you're looking at AUCs that is published from the AI algorithm in addition to sensitivity, specificity, and others. And so when one looks at the data, and this is a recent compilation from a nice review paper, the AUA for cancer detection in the last 3 to 4 years has almost reached 100%, 98 to 99 or 0.99%. And when you look at the kappa statistics, for general pathologists, it's in 0.6, 0.7 range with Gleason grading and grade grouping, again, through AI algorithms, is just significantly improved. So what can AI realistically do for us when we are practicing these cases? We want to make sure, can someone just tell us which slides are benign, very likely to be benign, which are atypical, and which are cancer? Those that are atypical, can we just get recuts and IHC and get the work moving? We need to annotate the slides, suggest a Gleason score, and quantitate the tumor. And also document very important findings that we have to report, including cribriform morphology, perineural invasion. So let me show you that AI, again, will show by addressing these issues improves quality and efficiency and consistency in cancer detection, quantitation, grading, et cetera. So I wanted to recognize here our colleague, Dr. Santa Rosario from Core Plus, and Mariano is going to speak about their incredible wide experience. But Santa comes in the morning, sometimes just hopefully early in the morning. He lives in beautiful Puerto Rico, has a cup of coffee, looks at the number of cases he has. He has this big screen instead of microscope. And then he sees the foci, and he applies what's called a heat map. And a heat map is basically, if it's red, there's a very high likelihood of cancer. If it's blue, it's very likely benign, right? So in his workflow, I'm just picking up a day in the life of Dr. Rosario. Say he has 20 cases of prostate biopsies to look at. He knows already, sitting at home probably, that he has 379 cores to look at that day. But most interestingly, he already knows there are 8 cases with cancer, 8 without cancer, but they are atypical, so he may need to work it up. And there are some foci that he needs to evaluate. The rest are benign. And so when he's looking at the case, let's say he's looking at that particular case that is shown here by the arrow. What this case shows that there are, from the 20 cases, from this case, there are 7 parts that are benign, 3 cancer and 2 atypical. So he basically needs to focus on the cancer foci, make sure that they are cancer. Atypical foci, does he need to even work them up because the cancer foci, and really focus on what is going to matter for this patient. Do I need to work up the atypical foci? Because has he reached the threshold for active surveillance? So it really helps him guide through the cases. And so here is a case that he has. He applies the heat map, and as he's applying the heat map with Mariano, who's going to speak next, they have developed a great AI system in collaboration with Ibex. They drop that information into the report. And so as he's looking at the case, he's already got the case all signed out. So here's an example of a case. You can see there's a small focus at the edge. He applies the heat map. It's kind of the in-between yellow color, so not diagnostic of cancer. There's a small focus, unusual looking morphology. So he needs to apply immunohistochemistry, and the immunohistochemistry shows that this is a focus of cancer. So clearly expedites his case review, a real-time quality control, and a confidence at what he's looking at. He can then measure the foci of cancer. If there are 2 foci, he can measure them and make it discontinuous and add it up. Now, this is Ibex's experience. As I said, the literature, when we compare with each other, shows an error rate of about 2.2%. Now, this is the Ibex experience. A lot of this work has been published, and the error rates for diagnosis of foci of cancer. It doesn't necessarily mean whether it influenced care, but at least understanding, and we know that all the foci are important and the quantitation is important, but just looking at the number of foci that are potentially missed, the ranges from as low as 2 and 1.8%, these were large academic centers, to more in the 12 and 13%. The average has been in the 6 to 9% range for these patients. Now, Yossi, who's the CEO, reminds me that Wales is a country, and that country has entirely adopted AI, and they're using it across the country, and they're using Ibex. And this is their experience in over 6,000 cases. A staggering positive predictive value of 99.8%, negative predictive value, again, in that very high rate. There's a 13% reduction in identifying those small foci. Of course, incredible efficiency because you already know which are the foci to look for. 49% reduction in immunohistochemistry. This is important in value-based systems where you want to do the right thing in terms of making sure you get the least number of tests but the most accurate diagnosis for the best cost. Increased confidence of diagnosis, and of course, the turnaround time improvements. That was just very impressive. Now, in the journey to FDA approval, Ibex first got the CE approval. This was a study performed in 2021, and they showed that just by using Ibex in 40 cases, the pathologists were already increasingly efficient in using Ibex prostate and then in practicing that in pathology. And they showed, you can see it on the slide, there's an improved accuracy by 32%, productivity gains by almost 40%, and the faster turnaround time, it would take almost 1.8 days when you go back and forth looking at the case, immunos, recuts, to almost an average of 9 minutes per case. So recently, Ibex received the FDA approval for their Ibex AI product, and I'm going to show you a little about what that means. But as you all know, as pathologists at the high level, the FDA is a regulatory body that has stringent evidence requirements that in order for a medical test to be approved by them, it ensures patient safety, efficacy, accuracy, reliability, improved clinical utility above the standard of care. So it has to enhance what we are doing and beyond that. In anatomic pathology, their involvement has been relatively restricted. They've approved 5 scanners, 4 AI algorithms, including Ibex's prostate algorithm. And in the field of companion diagnostics, using the term very generally, they've been very involved with those that guide certain therapy, such as HER2 and PD-L1. So the Ibex approval for the prostate detect program is when Ibex showed the ability of AI to generate heat maps that identified small and rare foci of missed prostatic cancer. So of course, if you put the slide under the microscope and it's cancer, it's not an issue. It's the small foci of cancer, and they showed that the relevance of the AI algorithm being able to do it. So the intended use case from the FDA is to identify high likelihood of cancer cases initially diagnosed as benign, and then by a further review is picked up by the AI algorithm and the pathologist to detect as cancer. It is for the detection of adenocarcinoma in this setting, and because FDA has very stringent rules of which scanners, for the purposes of this FDA approval, the Ibex had worked with the Finis scanner, but it is integrated in multiple IMS systems. And there were several studies. I'm not going to go into the details of the study, but give you some headlines. So there were 2 types of clinical studies that were performed and 3 types of analytical studies. I'll walk you through the clinical studies. But basically, you can see the rigor. It had 5 sites, including academic and large community practices, and in an international setting, large number of pathologists being involved, and over 8,000 slides being reviewed. So one of the more interesting slides for us to look at is the impact of an AI algorithm in cases that was submitted from 3 institutions as already benign. So these were all cases, almost 5,942 benign slides were submitted as not having cancer. And the headline news is that 13% cases were identified as cancer through a ground truthing of experts and then confirmed by the pathologist by the AI algorithm. So just looking at negative slides, you can see the impact. And if we were to take the 10% required review of second review by pathologist to pathologist, you can see that the sensitivity of pathologists picking up another focus is 9.4%. The sensitivity of AI algorithm picking up another focus is 81%. So there's almost an 8 times increase in the amount of cancer that can be detected by the AI algorithm. The other study, the first study that they performed also as part of this study, was they looked at cases which had both cancer and benign cases, right? And again, 3 sites, there were 12 pathologists, 3 review pathologists, 772 cases. And you can see that the sensitivity for detection of cancer was 92%, and you can see the confidence interval versus standard of care, which is 88%. That's showing the number of cases that were picked up by this. And the rate of missed cancers dropped from 9.5 to 6.1. So there was a 36% improvement in detection of cancer. Now, you can see the specificity is a little lower because you want the test to identify all the atypical foci. And if it is an atypical focus, you as pathologists driving this diagnosis should have the ability to order IHCs or not. So you want a test that's very sensitive in screening atypical foci, but not necessarily high specificity. And you can see that in this data. Ibex is also the first AI algorithm in the 5 that have been approved by the FDA, whose heat map has also been approved as part of the FDA approval process. So the heat map, as I showed, is if it's red, is cancer. So if you can see at the bottom, if there's a 0.95% high likely dark red kind of color hue, there's 100% specificity and 99.6% positive predictive value. Now, through 30 years of evaluating the literature, when I saw these data, I said, that's nonsense, right? But when you see this kind of data published from multiple algorithms, from multiple centers, we know that there is a certain level of consistency in these AI algorithms that we as humans did not have when we performed these studies at a human level. Again, when it is blue, it's negative. You can see the sensitivity of a blue being negative is 98%. With a negative predictive value, again, 99.8%. So you can feel sufficiently comfortable that the blue parts are negative. So in summary, what is the value proposition I've shown you here and how this Ibex AI program is going to help us? From us as pathologists, the first is just the reduced anxiety and stress of screening. I mean, that's the biggest issue. And then you get phone calls in the middle and tumor boards and clinicians walking in. and then trying to find the smallest foci is really the biggest stress factor in our lives. This is now an open book exam. You have the answers, you go in and confirm it, right? It also gives you an increased diagnostic confidence, a real-time quality assurance that someone is a partner with you looking at these cases. There's clearly demonstration of increased efficiency, and we know that all of this then allows us to focus on things that are really important. Should I work this case up? Is this patient eligible for active surveillance? Does this patient require some ancillary testing? From our physicians, this is an incredible opportunity too, because it gives them greater diagnostic confidence that the pathologist on whom they rely on entirely for whether they should put a patient on active surveillance or not, or whether they have cancer or not, is got a real-time QA assistant. Faster turnaround time, there's no physician who doesn't like that, and you can see that the impact of that is very high. And so the physician satisfaction is always incredible. From the field of pathology, of course, this brings us much more into the digital world. The rest of the hospital systems are going into it. The ability to standardize how we are looking at cases. And most importantly, as Ibex unfolds this throughout the world, the same level of expertise is unfolded through other parts of the world, essentially democratizing the process and giving access to subspecialized level care. And let's not forget, at the end of the day, we are here to serve our patients, and our patients are the ones who benefit most with a higher degree of accuracy and therefore, in a sense, providing health equity opportunity for them.